Hello, everyone, and welcome to another episode in our Smarter in Minutes series. My name is Dr. Onyema Ogbuagu. I'm an associate professor of medicine and the director of antivirals and vaccines research program in the section of infectious diseases at Yale University School of Medicine. Today, I'm joined by my colleague, Dr. Natasha Bhuyan, who is an assistant clinical professor in family, community, and preventive medicine in University of Arizona, located in Phoenix, Arizona.
Hi, Onyema. Thank you so much for having me.
Over the next few months, we'll be posting a series of these short CME-certified videos focused on the management of patients with COVID in the outpatient setting. This activity is jointly provided by National Jewish Health and Bonum CE. This program has been supported by an educational grant from Pfizer. Please be sure to let us know who you are and complete the pre-polls in the tweets below or using the QR code that should be showing on your screen. Now, today we'll be talking about long COVID, and we know that the terminologies and nomenclatures for this medical condition are evolving both in the lay public and the medical community. It's frequently referred to as post-COVID syndrome, or a more technical term, which is post-acute sequelae of SARS-CoV-2 infection, the so-called PASC, as well as long COVID. And these are just synonymous terms to describe a condition marked by either continuation of COVID-19 symptoms over a prolonged period or the emergence of new ones after initial recovery from the acute phase of the COVID-19 illness. Generally, people who suffer from long COVID are referred to as long haulers. So, Natasha, we've all seen the questioning of the reality of long COVID as a syndrome, particularly on this platform. So, can you discuss some of the data we have that even establish this condition as a medical reality?
Yes, long COVID is real. At least 65 million individuals are estimated to have long COVID, with cases increasing daily. Long COVID is recognized as a condition that could result in disability under the Americans with Disabilities Act. And there is non-uniformity in definitions for long COVID. So the NIH describes it as a condition which encompasses persistent, new, or recurrent symptoms and conditions like cardiopulmonary injury, neurocognitive impairment, or new onset diabetes for more than 4 weeks after the initial COVID-19 diagnosis. Now, the World Health Organization describes it as the continuation or development of new symptoms 3 months after the initial SARS-CoV-2 infection, with the symptoms lasting for at least 2 months with no explanation. So, Onyema, there are a laundry list of symptoms that are attributed to long COVID. Can you tell us a little bit more about these?
Yeah, thanks, Natasha. You discussed the complexity with having a uniform definition for COVID-19. And I think either equally complex, if not more complex, is also just the syndrome complex and the presentations of long COVID. And so, long COVID could be one symptom, or it could be many symptoms or constellation of symptoms that range from just mild symptoms to those that on the extreme end are actually incapacitating and prevent people from even in many cases being able to return to work and definitely negatively impact their quality of life. And some of these syndromes affect not just one organ system, but can actually be multi-systemic. And so people with long COVID tend to have symptoms which can range anything from weeks to months to years after an initial COVID-19 infection. It does appear that it tends to be a little more common in adults, a little more common in people who have much more severe illness, but still occurs in young individuals as well as those who may have had milder forms of the disease. And, for some of these individuals, they have symptoms that are ongoing, for periods that should exceed the period of convalescence. And there are some individuals who develop new symptoms weeks to months after the initial recovery from COVID-19 syndrome. Just to highlight some of the symptoms that do occur, things like respiratory symptoms like cough, shortness of breath. We know individuals also have lingering symptoms like loss of taste and smell. And individuals just have, generalized symptoms like fatigue and headaches and, prominent neurologic symptoms such as issues with memory and mood lability, etc. Some individuals also have unique syndromes such as postural tachycardia syndrome, the immune system disorders such as autoimmunity, We know that there have been increased rates of endocrine issues, such as increased rates of new diabetes diagnosis in individuals who recovered from COVID. And there are certain things that are also uniquely tied to specific organ systems, such as cardiovascular, where there are reports of myocardial inflammation and even cardiac injury post COVID 19. Some individuals continue to struggle with having sufficient gas exchange, given just the degree of pulmonary injury that have occurred that in some cases progresses to fibrosis. And then you have a whole slew of neurologic system issues, dysautonomia, issues with neuroinflammatory syndromes. And even for the cardiovascular system, we've seen even higher rates, for example, of increased risk of thromboembolism episodes occurring in those individuals. So there's a whole myriad and constellation of symptoms and syndromes that individuals with COVID-19 continue to exhibit. And we continue to learn as we continue to build growing cohorts of individuals with these syndromes and better define them as we go along. So Natasha, given these what appear to be a long list of symptoms and syndromes that people with long COVID do report, what can you tell us about the current knowledge about the prevalence and etiology of some of these symptoms and syndromes?
Well, data on long COVID incidence, duration, the natural history, and etiology are still emerging. Now, prevalence estimates, they widely vary, and that's because of the differing symptoms, conditions, temporal criteria, different study settings, and even symptom and condition assessment. One assessment found that the incidence of long COVID among patients with mild to moderate disease was about 23.4%. And among severe and critical hospitalized cases, it was about 62.5%. And although COVID-19 in children is usually of shorter duration with low symptom burden, one UK study did find that some children ages 5 to 17 with COVID-19 experience prolonged illness with a duration of 28 days or longer. And now this phenomenon tends to be more common in older children than younger children, and most children overall recovered by day 56. Now, multi-organ system effects of SARS-CoV-2 infection documented in most, if not all, body systems include cardiovascular, pulmonary, renal, dermatologic, neurologic, gastrointestinal, endocrine, and psychiatric. 2 to 14% of patients developed postural orthostatic tachycardia syndrome, known as POTS, after having a COVID infection in one study. And similar symptoms like vertigo, fainting, fatigue, rapid heart rate, and brain fog are shared, and POTS can actually be triggered by underlying viral infections. Now, long COVID is attributable to different underlying pathophysiologic processes, including organ damage from an acute phase infection or complications from a dysregulated inflammatory state. There could be ongoing viral activity associated with an intra-host viral reservoir, autoimmunity, inadequate antibody response, and other potential causes. So one of the big questions is, how do we determine a diagnosis of long COVID? What testings and assessments should we use?
That's a very loaded question, Natasha, and I want to highlight very important caveats here. So we need to recognize that there's no one syndrome that comprises long COVID, and as we've previously mentioned, can be very complicated diagnosis to make. And recognizing that post-COVID conditions can mimic many other spectra of medical illnesses, which can mimic each other. And so really attributing symptoms to long COVID can be very, very challenging, and especially in the absence of any clear biomarker for this syndrome. Certainly, individuals will have a prior history of COVID-19, which then could be suggestive that whatever syndrome complex they have post in the absence of any other explanation could be related to COVID-19. And as such, many post-COVID conditions can be diagnosed clinically based on history and physical exam findings that support a syndrome. However, we need to be aware that in many of these cases, laboratory tests as well as imaging studies can often be normal. or non-diagnostic or uninformative. But I think, like any other medical condition, a robust medical history, a thorough physical exam, and a somewhat aggressive diagnostic workup would be very helpful here to rule out other conditions that could mimic long COVID, but also to assess for what could potentially be urgent or life-threatening clinical conditions that could occur as part of post-COVID. Some that easily come to mind would be things like a pulmonary embolism, myocardial infarction, and strokes that can be part of a post-COVID-19 presentation. Some people argue that being a little more conservative, in the first month to 3 months post COVID-19, and then certainly for symptoms that persist longer than 3 months to be more aggressive, if you will, with the diagnostic evaluation. So, certain things we can look for in a physical exam, certainly, of course, vital signs, including orthostatic vital signs, if that's important, measuring the body mass index. And don't forget pulse oximetry. And sometimes even under stressful conditions such as exercise to unmask any issues with oxygenation in these individuals and assessing for fatigue and malaise, for example, with walk tests, etc. Also remember that we need to make sure that we're recording these abnormalities and within our electronic health records. And so these are really important to assess where patients are at baseline and also assess them over time. And there are many tools as well which can help to evaluate some of the unique syndrome complexes. There's a long list of laboratory tests that could be evaluated. Again, some of these are, to get baseline labs. If you've evaluated patients before, they're a good comparator to what their pre-illness baseline was. And some are also to rule out other concurrent medical conditions such as endocrinopathies also that could explain some symptoms people have. So, basic tests like complete blood count, electrolytes, renal function tests, basic inflammatory markers, tests for thyroid function, and assessing things like vitamin deficiencies could be really important. And then also assessing for mimics such as rheumatologic conditions may be important to also strengthen or rule out the diagnosis of long COVID. And don't forget functional testing, particularly for those who really describe limitations easier with their respiratory status or their physical abilities, I think can be very helpful to document their progression over time. And so, we've talked about this, evaluating the patient, and we recognize that, individuals, who are long haulers are really suffering. And like you said, has been recognized by the American Disabilities Association as a condition that's really life altering. And so what can be done, or at least within the bounds of what we know currently, what can be done to manage this syndrome, Natasha?
Yes, well, most importantly, symptoms that are not explained by or out of proportion to objective findings, they're not uncommon after COVID-19, and they should not be dismissed, even if there's not yet a full understanding of their etiology or the expected duration. Now, the goal of medical management of post-COVID conditions is to optimize function and quality of life, and it could involve the following. So one is vaccinations, because this reduces the incidence of long COVID. We want people to take a holistic, patient-centered approach to improve quality of life and function. That might also include facilitating a standardized, trauma-informed approach to symptom assessment and conditions. Also setting expectations with the patients and their families that outcomes among long COVID patients differ from time, and resolution is really variable. When symptoms don't resolve, continued follow-up and testing may be required, particularly when there is so much to be learned about long COVID. Establishing partnerships with specialty care is also critical, and connecting patients to social services and resources like disability, support groups, or accommodations for work or school. There's also emerging evidence that early treatment with Paxlovid may help. Now, a VA cohort study found that in about 280,000 people with SARS-CoV-2 infection who had at least one risk factor for progression to severe disease, treatment with Paxlovid within 5 days of a positive COVID test result was associated with a reduced risk of post-COVID conditions across the risk spectrum in this cohort, and regardless of vaccination status and history of prior infection. So developing a comprehensive management plan based on the patient's presenting symptoms, underlying medical and psychiatric conditions, personal and social situations, and their treatment goals is key. use shared decision-making and transparency. And symptom management can improve many post-COVID conditions and may involve lifestyle components like medications, peer support groups, resources, physical therapy and occupational therapy, speech and language therapy, vocational therapy, as well as neurologic rehabilitation for cognitive symptoms. Now, our knowledge of long COVID has advanced significantly. What is in the pipeline from a research standpoint that may shed some additional light on long COVID?
Yeah, thank you, Natasha, and we'll continue to really address this issue for the next 5 or 10 years to come. And so, yes, we will have to lean a lot on research to better understand long COVID better. There are some challenges by the different case definitions that are out there, which don't allow comparing groups, for example, one to another. Many of the studies do not have comparator groups as a control for individuals who meet the definition of long COVID, which is critically important for cohort studies. And again, just the overlap between the symptoms of long COVID, other medical conditions, and also for individuals who had severe disease, particularly those who were sick enough to be in the intensive care unit, and all the other sequelae of a long hospitalization that could mimic also long COVID and also cause some overlap symptoms. So it's very challenging landscape for cohorts to be followed. However, very early on in the pandemic, once it was recognized that individuals were having prolonged symptoms or new symptoms post initial recovery, the National Institute of Health established the post-acute sequelae of COVID initiative to further research on the condition. And one of such is the RECOVER trial, which is researching COVID to enhance recovery initiative that's received robust funding to research this. And some of the initiatives are to leverage long-term cohort studies, either from EHR or large health systems, databases from individuals who've had SARS-CoV-2 and recovery. There are new studies on people with long COVID that are funded. There's lots of work on biologic specimens just to understand the range and severity of injury that SARS-CoV-2 does to brain and many other body organs. And then there's also, real world studies looking at patient related outcomes, patient experiences at all levels and stages of the illness, as well as meta cohorts looking at both adults and children from all kinds of contexts, including long COVID, for example. Some of the pertinent questions for research moving forward, again, will continue to revolve around what is the spectrum of recovery from SARS-CoV-2 infection? Does it differ across different patient types or different patient populations? We'll continue to ask questions about the epidemiology of long COVID, such as, how many people continue to experience this. Also trying to understand the basic biological mechanisms of some of these long-term effects that individuals have. And I think if we better understand those, then we can now then move to specific therapies, if you will, to at least address certain conditions or not. And then also, what does SARS-CoV-2 infection trigger within organ systems that raises the risk for other conditions such as chronic heart and brain disorders, as well as the endocrinopathies that we've identified. Now that we know a little more, or maybe a lot more, about long COVID, Natasha, what do you think are the key take-home points for our audience today?
There's a few key points. Data are emerging on long COVID or post-COVID conditions, which includes a constellation of physical and mental health consequences experienced by some patients that are present for 4 or more weeks after a COVID infection. Multi-organ effects of a SARS-CoV-2 infection are diverse and include most, if not all, body systems, including cardiovascular, pulmonary, renal, dermatologic, neurologic, gastrointestinal, endocrine, and psychiatric systems. The goal of medical and symptom management is to optimize function and quality of life. There is emerging evidence from a VHA cohort study that Paxlovid may reduce the risk for progression to post-COVID conditions. And NIH, through the RECOVER initiative, is conducting ongoing cohort research to address many of the knowledge gaps about long COVID.
We'd like to thank you so much for joining us today. Please complete the post polls in the tweets below or by using the QR code shown on your screen. And don't forget to claim your free CME. Click like and follow for more social media-based CME from Bonum CE.